All right, we'll go ahead and get started. We're so thrilled that everyone is here. We know a few more people are joining, but just to welcome you all, my name is Kelsey Berry. I'm a faculty member here at the Center for Bioethics at Harvard Medical School and a research partner over at the Edmund and Lilly Stafford Center for Ethics. And it's a real pleasure for me to welcome all of you to the Harvard Medical School Organizational Ethics Consortium. We have a really timely topic for you today on mental health and the future of psychiatry. So it's really relevant for those of us who might have seen challenging shortages in mental health care and just wondering how the profession is part of confronting these and other core challenges going forward. So before we get there, let me say a quick word about this consortium. The core of the Organizational Ethics Consortium is really this monthly meeting that we run during the academic year. And what we do here is we bring together leaders and ethicists in the healthcare sector who are grappling with challenging issues that arise for health systems and looking at how to align their organization's policies and practices with some form of the right and the good, as is the case today with, for example, a sustainable and responsive mental health care system. And our aim in these consortia meetings is not only to kind of whet your appetite for appreciating the potential power of organizations as a force for the good through examples and showing various models for how they might bring ethical values into their strategies, but then also to consider some of the challenges that organizations and their leaders face in this work as we all look to the role that we can play in contributing to a more ethical and just health sector. So you can see this is one of a number of public consortia series that the Center for Bioethics runs every Friday afternoon. And you can sign up on the newsletter to receive information about the upcoming consortia, including the Joint Clinical Ethics and Organizational Ethics Consortium at the beginning of December. So we are set up in a meeting format today to support a robust conversation with our speakers. And we hope that those who are comfortable will indeed turn on their videos. We welcome everyone to introduce themselves in the chat box so that we know who's here. I'm going to get it started. And we'll hear first from our speakers, and then we'll invite you to share your questions and thoughts by using the raise hand function found in the reactions tab at the bottom of your Zoom screen. You can also share questions and observations in the chat box. I'll try to track those. But if you really want to get your question or thought into the conversation, please use the raise hand function once we turn to audience Q&A. So back to today. As you saw, we're looking at contemporary challenges in mental health care, and particularly the role of organized psychiatry in addressing them. So we have three internationally recognized leaders in psychiatry with us, who through their recent work with the American Psychiatric Association, which is the world's largest psychiatric organization, have reimagined how the profession of psychiatry can set its norms and targets to fulfill its responsibilities to the population in the context of significant need, new technologies, and other pressures. Before I formally introduce our speakers, I just want to highlight one key point for us as an organizational ethics consortium, which is that today's session gives us somewhat of a different angle on so-called organizational ethics. So at least in this consortium, we have often looked to ethical questions confronted by kind of classic brick and mortar organizations in the health sector, that is hospitals or insurers, biotech companies, for example. But there are a lot of major organizing structures that exist in the healthcare system that significantly determine how care is delivered, how it's financed, and thus what we can achieve, right, as a society, including organizations like the American Psychiatric Association that specifically guide the professionals that practice within these brick and mortar institutions. And so in many ways, what healthcare delivery and payer organizations can achieve depends heavily on the norms and the values of the professionals that they're working with. So today's work is to jump to this unique organizing force of a professional association and look at how its strategies and ethics shape the health sector. So without further ado, I'm really excited to have this group of speakers with us. We have first Dr. Rebecca Weintraub Brendel, immediate past president of the American Psychiatric Association, who convened the work that you're going to hear about today. And Becca, as we refer to her fondly here at Harvard Medical School, is an ethicist, a practicing psychiatrist, a lawyer, a master educator. Beyond her extensive career in leadership and psychiatry, we're lucky that she's here at Harvard Medical School directing our Center for Bioethics, the master's program within that center, and then is also director of law and ethics at Mass General Hospital, the Center for Law, Brain, and Behavior there. So thrilled to have you with us, Becca. We also have Dr. Bob Trestman, who chaired the work that you'll hear about today for the APA. And Bob is a nationally recognized expert in psychiatry and in population health, whose career has taken him from focused work in leading psychiatric care provision in correctional settings and working with justice-involved populations and developing innovative mental health programs, to now he's chairing psychiatry and behavioral medicine at Virginia Tech Carilion School of Medicine and Clinic. Beyond leading the work that you're going to hear about today, Bob also chairs the APA Council on Health Systems and Financing. He's leading the APA's new working group on the future of AI in psychiatry, and serves as the liaison between the American Psychiatric Association and the American Hospital Association. So we're glad to have Bob with us. And finally, we have Dr. Charles Dike, who's the chair of the APA Ethics Committee, and also authors the psychiatric news column Ethics Corner on contemporary ethical issues that are encountered by psychiatrists. Charles's career work at the intersection of psychiatry, public health, ethics, diversity, and inclusion has recently been recognized through a named scholarship with the American Academy of Psychiatry and the Law, where Charles is also currently the president-elect. So Charles is at Yale University School of Medicine, where he is a professor of psychiatry. He co-directs the Law and Psychiatry Division there, and he also serves as medical director of the Connecticut Department of Mental Health and Addiction Services, and is going to leave the meeting right at 2 o'clock today so that he can go and fulfill responsibilities in that role immediately following our meeting. Oh, you became president of AAPL 2 days ago. Amazing. So no longer president-elect, but president, in fact. Congratulations, Charles. So we're really thrilled to have all three of you, and I'm going to turn it over to Becca to get us started.
Great. Thanks, Kelsey. And I just want to say what a particular pleasure it is to be able to bring two parts of my life that are near and dear to me together, the APA and the Center for Bioethics. And Kelsey didn't introduce herself, but in the years since she's been a postdoc at our center, her work with another psychiatrist, Jim Sabin, and another wonderful colleague, Charlotte Harrison, in bringing together issues of organizational and institutional ethics and thinking about in health systems has really been groundbreaking, and in many ways made thinking about this kind of work really possible down in Washington at the APA. So thank you to Kelsey as well, and to my dear friends and colleagues, Bob and Charles and Kelsey, for being along on this journey with me. So I wanted to start by setting the stage and framing some of the issues, and then pass it over to Bob and then Charles to take us through the work itself. This is the headquarters of the American Psychiatric Association in Washington, D.C. We're located at the District Wharf, which is a new development on the southwest side of Washington, D.C. And APA, in fact, had moved out to Virginia, and this brought us right back into the district itself. And we're very proud to be an anchor tenant of this development that is now sprawling. So in a way, it's you can see our sign right there. It's present 2 times on the outside of the building, but to us, it means it has really important ethical significance too, that we are not hiding that psychiatry. In fact, we're leading with it. And we believe that it's everything that we need to do to be serve the populations and people in our country and beyond who really need mental health services. And I'll say a little bit more about that. So just to give you a sense of the scope of the APA, we have approximately 38,000 psychiatrist members and about 200 staff that support the administration. The APA itself is a 501c6 organization. If you're not a lawyer, what that means is we're a limited nonprofit. It means that we are able to engage in lobbying and political functions. So we're not fully tax tax exempt the way a nonprofit would be. So the C6 is the parent organization. And within that, the two things that it's important to know to really understand the scope of the work that we do have a foundation that is a full nonprofit, tax exempt organization, the APA Foundation. It has a separate board that shares some members of the APA board and has an independent administration, but is chaired by the CEO of the APA. And then we also have a political action committee, a 527. And in fact, one of the things APA does, which you'll see a lot about, is a significant amount of lobbying and policy work to be able to affect the policy changes and structures that support the work of advancing mental health. So what is the work that we do at the APA? Our mission is to promote the highest quality care for individuals with mental illness and substance use disorders and their families. We do that through psychiatric education and research. We advance and represent the profession of psychiatry, so we speak for psychiatrists as well. And we serve the professional needs of our members. And it turns out that oftentimes professional organizations are criticized for guild interests. But in fact, as you'll see, we are at a unique period in time to lead from our important moral commitments, given the alignment both of what's in the interest of both psychiatrists and our members, as well as those who we serve. Okay, so the question really that we came to, and I got to appoint this task force, but this goes to my mother's favorite saying, never ask if you can help in my kitchen unless you're really serious. Bob challenged me during my year as president-elect to say, how are we going to evolve as a field to sustain our vision and meet our mission? How are we going to make sure that psychiatry is really leading as the premier psychiatric organization advancing mental health as part of general health and well-being, right? How are we going to promote universal and equitable access to care? How are we going to do that with educate and do research to support that mission? How are we going to serve our professional needs and advance our profession? And so it's no surprise, right? Why we need this, why we needed to think about the future of psychiatry, right? So these are articles both from journals as well as from the articles from the Boston Globe and other places about how much of a mental health crisis our country is in. People have referred to it as a twin pandemic. And we know that those who already struggle to access high quality care and are most in need are also struggling to access desperately needed mental health care. And so children in particular have been affected. Stories we've all heard about, tragic, of kids being in emergency rooms because there aren't available psychiatric beds and services. And really the amount of psychological distress more generally throughout our society after the COVID-19 pandemic caused great disruptions to all the structures that really held us together and created the kinds of communities and resources to keep us mentally healthy. So in addition to the fact that there's increased need, this is really setting up for you the moral imperative of psychiatry's leading to do something about the mental health crisis. We actually don't have enough psychiatrists. So the psychiatric workforce is aging, and the supply of adult psychiatrists is expected to decrease by 20% in the next 7 years, while the demand for services continues to increase steadily. So if you model this out, it looks like we'll be left with a shortage of more than 10,000 fully trained psychiatrists over the next 6 or 7 years. So that's several thousand per year. And there are other issues as well. So there's a marked uneven distribution of psychiatrists and other mental health professionals in rural areas. And in areas that do not have large population centers. So there tends to be a concentration in cities and in academic medical institutions. We know, for example, that the Boston area has a disproportionate share of psychiatrists compared to the population in the rest of the country, and yet it's still incredibly difficult to access treatment. We hear day in and day out from those in our community. The good news is that people want to be psychiatrists. So we matched 99% of our slots to over 2,000 psychiatrists in the last match of 2022 that data is available for. We've been increasing those slots for about 5% per year. And you remember I talked about the policy work that APA does and our lobbying efforts. At the end of 2022, Congress funded an additional 200 graduate medical education, so residency and fellowship slots, and 100, a full half of them went to psychiatry and psychiatry subspecialties. But it's still not enough, right? 100 extra per year is not going to make a dent in 12,000 very quickly. And then we're also facing other structural challenges to being able to deliver mental health care around parity and funding models. The good news is that Congress passed the Mental Health Parity and Addiction Equity Act in 2008, which really follows the core principle that insurers cannot discriminate or have lower coverage for mental health and substance use disorders than they do for other medical conditions. And there are wide-ranging implications of all the ways that parity might be enforced. And over time, APA has been a key strategic partner in closing the loopholes in the Mental Health Parity Act to ensure now that there's good enforcement at the state level. That was also part of our 2022-2023 legislative agenda, to make sure that local government health plans are also covered by the Mental Health Parity Act, and to make sure that we did a lot of work with the Department of Labor and others to make sure that enforcement really happens, so that individuals, when they pay for a health plan, have access to both medical care and medical care for their mind as well. So full coverage, and along with the knowledge that there's no health without mental health. All right. So those are some of the challenges that we were facing. And these are some highlights of some of the things that I did during my presidential year. But we came up with an opportunity we weren't expecting in January of 2022, when the White House announced that mental health was going to be one of the president's priority areas. This came out on the day of the State of the Union address. So we knew that we really needed to get out in front of this and it helped us be able to deliver strong messages within our communities through the media. In the bottom left corner is testimony. I was one of 3 APA members to testify on 19 mental health related bills in the House Committee on Energy and Commerce. And then also really to highlight some of the other challenges that are happening within the healthcare professions, as well as society, thinking about things like depression and burnout and how we can help care for each other in broad ways. But even with all that work we're doing, and even with declining numbers, we have some other major challenges for our workforce. Okay, so this is a scatter plot that shows, was a survey of APA members on a scale known as the Oldenburg Burnout Inventory. And basically what it shows is, as your years of graduation from medical school goes up along the x-axis, anybody who's over that orange line is at high risk for burnout. So what we see is our workforce in the highly productive mid-career years, early to mid-career years, is at a high risk for burnout. And even beyond that, we see a similar plot showing that we have a number of our members This was about 2,800 psychiatrists surveyed from the APA. About 1 in 5 were also at moderate or higher risk for depression. So we also know that our workforce is not healthy, and we have some major work that we need to do to keep psychiatrists well, advocate for the profession so that we can also make sure to fulfill our obligation to those who we serve. Now, here's the challenge in all this. People say, okay, go see a psychiatrist if you have a mental health condition. And in fact, psychiatrists can't do this alone. So we make up only about 6% of the workforce. I'm grateful to Bob for really compiling this information and helping us put it together in such a poignant way. But what we know is that as psychiatrists, we are going to need to partner with other mental health professionals, as well as other physicians, in being able to meet the overwhelming need for mental health services in our country. This is something that is a moral imperative. This is our mission. This is what we do. This is what we stand for, and this is what's right. The problem is we have so many challenges in that, some of which I've laid out for you, including our numbers are never going to be adequate ourselves. And so one of the things we did was this thought experiment with our board, asking about where psychiatrists' strong suit might be. So what are the things that psychiatrists do that other mental health professionals don't do as a way of leading in what we might do? And you'll see very clearly that the medical piece comes out, but there are a lot of other pieces too, prescribing, leading our profession, evaluation that stand out less prominently. But this was just a way to begin to say, gee, maybe we could think about the places in which psychiatrists could take leadership in making sure that every American has access to high quality, affordable mental health treatment. And so this is really the crossroads that we found ourselves at, I stayed awake at night worrying about until I realized that I could phone my good friends and colleagues who are on this call with me today to really ask the question of how APA can focus both on the current situation and meet the immediate need for mental health treatment. How can we represent our member interests in addressing burnout and depression risk and workforce health? And then how we can align that with patient interests at the present in getting high quality, affordable care. And then at the same time, really model out a roadmap for the future. So how we could devote significant resources to the future practice of psychiatry to proactively solve problems. And so with that, the board supported me in forming a work group to create a roadmap of recommendations to lead APA's strategic direction for psychiatric practice and research over the next decade. All of this in the service of our vision to have a society that has available, accessible, quality psychiatric diagnosis and treatment, and to answer 3 specific questions. What will the future look like and require? How can APA advance that future? And what do we need to do to get there? And then, as you'll see here, I had the honor of appointing Bob Trestman to be the chair of this work group. He graciously accepted, and we put together a broad range of psychiatrists, including Charles Dike as chair of the ethics committee. We believe that if we didn't get our ethical responsibilities of the profession front and center in doing this work, then we were sunk from the beginning. This is really sort of the lasting legacy of Jim Sabin, who really taught us all about organizational ethics, really in making very clear that if we don't have the ethics voice front and center, we will lose it. And so there were 2 strategic aims. One was to establish and maintain APA as the thought, knowledge, and practice leader in quality mental illness diagnosis and treatment. And all of that was to support APA's policy and advocacy agenda about all the ways that we could support that work, which Bob will talk to you about. And with that, I'm going to pass it over to Bob to take us through the work that the group did.
Thank you. And so let me frame this in context. Think about everything we're going to be talking about, everything you've heard in the tension between ethics and pragmatics in a country where healthcare is not a human right and it is a commodity. Those are the background issues in which we live. And there are conflicting obligations that physicians have to the patient, as well as to their own families and to the field overall. So how do we balance that? And how do we change and evolve? So I'm going to focus primarily on how we began the work, and I'm not actually going to talk about the final results very much at all. Those are available publicly on the APA website. And they were really the results of the last slide that Becca had shared, focusing on those multiple dimensions. But let's talk about what's driving these concerns. Becca, next slide, please. So our goal in all of this work was first to think about improving equitable and ethical access to care, knowing that care is not a fungible quantity. It is in truth treated as a commodity, but it is different. There are different levels of quality of care that can be delivered. We're interested in improving access in terms of early intervention, certainly in primary care, leveraging telehealth, use of all of the other professions, including nurse practitioners, physician assistants in both traditional and non-traditional settings. How do we expand and appropriately deliver high quality care through those other disciplines, not just ourselves? And how do we take a leadership role? Because if we don't assume responsibility for setting the standards of care, then they may be set by others with less overall concern or vision for the quality of the care that's delivered. And to deliver that, we need much more than the current and traditional process measures of quality, of how long does it take to get a visit? How many visits are there? Is the person satisfied with the care they receive? We need to look more and more at data-driven results in terms of outcomes. Are people's functional capacities improving, essentially in a dose-dependent way related to the care they're receiving? Using objective measures, whether patient or clinician derived, or eventually, if they develop, different biomarkers that would be appropriate and reflect accurately the disease state and the change in disease state. And we must focus on health equity, which has been profoundly distorted over the years. Keeping in mind that currently about 40% of all psychiatrists don't accept insurance and are charging out of pocket to those who have the disposable income to pay out of pocket for their care, further diminishing the number of psychiatrists who are available to provide care. And looking at the transformation that we are living in, the real chaos and the opportunities that large language models, that generative AI may offer us. We're thinking already that by the year 2040, there will be no more diagnostic radiologists. There won't be, because the quality of AI will be enough that we don't need to train people to do what an AI platform can do. Interventional radiology may grow dramatically. We need to think broadly about the future of what we as people can do with our training and leverage technology. Next slide, please. So what we have begun to do over these years, certainly the APA has worked to promote and educate people on the collaborative care model, a model that grew out of the University of Washington, is very well based on close to 200 peer-reviewed evaluations, randomized clinical trials, where we can support primary care and improve the quality of care provided using that model. We have helped through the APA to create billing codes that are now available through the Centers for Medicaid and Medicare Services, CMS. In most, if not all states, are using those codes. We are expanding telehealth rules beyond the public health emergency. And because of all the work that's been done, in part because of APA advocacy, audio only, rural access, equity focus continues unabated through the end of 2024 as CMS continues to reevaluate what those rules should be in the future. We continue to work on the development of appropriate, usable quality measures and our promotion of a registry internally called Psych Pro, the goal being that we can work to generate a national registry that we can use to develop databases so that we have the data to demonstrate whether or not psychiatrists do indeed deliver improved care compared to other disciplines, and if so, for what diagnoses, for what level of severity and impairment. These are the detailed questions that our society needs to be able to make informed decisions about how care can be delivered and how can it be apportioned optimally. On our smartphones and on our computers have proliferated. Most, if not nearly all of them, are unmonitored, unmanaged. How do we evaluate those apps? The APA now has on its website a tool that people can use to evaluate what are the qualities of an app that would be of benefit, what are limitations to avoid, and so forth. So we have worked to develop and to disseminate a tool that is being used routinely now by many organizations to determine whether an app is useful for their patients. And finally, we cannot separate out ethics and equity from reimbursement. Unless people are paid appropriately for the work they are doing, we're not going to get people to engage in treating people where they are losing money every time they provide care. Now, here is an additional tension that has existed and will exist. Historically, many more psychiatrists than most other fields were in private practice, not affiliated with a hospital or a health system such as the VA or a staff model HMO. That's gradually changing, and more of us as psychiatrists are employees of hospitals and healthcare systems. And as that dynamic is changing, we are looking at new opportunities to shift the conversation as we are entering a field and an area where more and more regulatory demands are requiring more sophisticated data analysis and access to computer support systems that most people in private practice cannot afford. And these mandates may shift what we do and how we are going to do them. So we are facing this dynamic. And please, as we're discussing this, do not forget what Becca just shared about burnout. There are a lot of people, the numbers keep evolving, and I haven't seen post-epidemic, post-pandemic numbers, but about 40% of psychiatrists are over the age of 55, and many of those are choosing to retire when they're 65 or earlier. And if we don't support our early career psychiatrists and others, they may opt to choose either working in ways that make their lives easy by not working with insurance companies and only working with the privileged, or really eschewing the responsibility and opportunity we have at this moment to change the dynamic. Next slide, please. So as a field, we can continue to advocate externally for enhanced funding. We can participate in conversations to reduce stigma, as we have been. We can certainly work to help develop, implement, and disseminate evidence-based treatments of mental illnesses and addictions. All of this we are doing, and we're doing a pretty good job of that. But we have to start looking internally at ourselves. Who are we? What is our identity as a psychiatrist, as a physician specializing in psychiatry? And what are our aspirational goals as psychiatrists? Next slide, please. We can certainly continue to advocate for enhanced funding, to participate in conversations to reduce stigma, to help to develop, implement, and disseminate these evidence-based treatments through the APA in collaboration with other organizations, working with CMS, working with the insurers, incrementally to do so. Next slide, please. But here's the rub. Keep in mind that 50 or more years ago, psychiatrists were arguing that psychologists should not be trained as psychoanalysts, and that only psychoanalysts that really know what they're doing are medically trained. That set up a dynamic to, in many ways, isolate psychiatry from the flow of medical care, and is a ghost that haunts many of us. When we seriously look at the years we spend, we need to think about what makes psychiatrists different from all of the other disciplines who are currently providing, remember, providing about 94% of the care that those with mental illnesses and substance use disorders receive. And even that number isn't enough to meet the current need. What makes us different? We very routinely and frequently and loudly, I might add, assert that our training is the difference. We spend 4 years in med school. We spend training in focused neuroscience. We spend 4 years in residency, and for many additional years in fellowships in subspecialty areas. We assert this gives us unique skills in differential diagnostics, in differential therapeutics, in the management of medical comorbidity, and the management of severe illness. And indeed, compared to other disciplines, this is extraordinary. Next slide. But the reality is different than the argument. We undercut this argument by often choosing to treat people who quite reasonably might be cared for by those with far less training. Patients with uncomplicated mood and anxiety disorders, moderate severity personality disorders, or subsyndromal disorders. Because again, these are the populations that will likely have a full-time job and will have disposable income, and to make it easy to get access to care and to avoid the potential stigma, frankly, of having a psychiatric diagnosis in their medical chart be seen by a psychiatrist out of pocket without medical records being available by the insurance companies. We may choose to do psychotherapy, but here our arguments for all these years of training work against us. Psychologists have far more training in psychotherapy than almost any psychiatric resident will get in almost every residency. Next slide. So here's the conundrum that we're facing. Many of us abdicate our unique medical training by not coordinating medical care of our patients who have straightforward and common conditions, such as non-insulin dependent diabetes, hypertension, hyperlipidemia, which might, by the way, be complications of the medications we are prescribing. And many of us choose to opt out of insurance reimbursement and accept only cash payments. from financially secure patients. But there are realistic reasons why the current market dynamics are pushing for the results we are currently getting. And that's the challenge we have to confront, that the reality of many of us who may graduate with hundreds of thousands of dollars of medical debt, many of us who were never trained in residency to lead teams of people in ambulatory settings, many of us were never trained to manage complex comorbid conditions in collaboration with other specialties. Many of us were not trained in how to be resilient while doing this and continue to take joy in the work we want to do and we're trained to do, because of all of the administrative burdens and challenges that we may currently face. Next slide, please. So, look, there again, as many in industry have said, I think Deming was the original guy who said this, that, you know, we are getting the results that our system was perfectly designed to produce. We are. So we need to really think about that. I'm not trying to blame anyone, because we are all doing what our society allows and supports. So we need to think about both the ethical tension and the pragmatic realities of how do we get from where we are now to where we need to be to provide more care to our patients at the highest standards, and do so ethically, equitably, and appropriately. So right now, a lot of us and really enjoy working with really smart, high-functioning, cognitively sophisticated patients who, again, typically can pay out of pocket to conduct psychotherapy at our own pace and using our own protocols that may or may not be evidence-based, that may or may not be an appropriate use of our time, given that many other disciplines could reasonably and appropriately deliver much of the cognitive behavioral therapies or the psychodynamically informed psychotherapies that many of us provide. We are avoiding the complexity and challenge of hospitalizing an acutely ill patient. You know, if you're an ambulatory clinician, someone needs acute hospitalization, unless you call 911 and just push the responsibility onto someone else, you're faced with changing the course of your entire day to help to manage that admission, unless you're part of an entire team. So the real world difficulty currently exists about finding community resources for those with social inequities who are at risk of, or who are indeed homeless, who don't have a steady job, who might not have access to, insurance that allows them to be compensated so they can afford to get medications that we want to prescribe. And indeed, in this world, in this culture, there is a pressure and a tension to support the autonomy of each physician. And as we look around at our microenvironment, what's our own income? So these are the tensions we grapple with. And these are the tensions that we grappled with as we worked through the work group's goals and the work product we developed. So next slide, please. Right? How do we focus on what we can do? Next slide. How do we start shaping for the future? Look, we're not talking about an overnight fix of the current day structure. There are many entrenched and highly well-funded organizations that want things to stay the way they are. We are talking about helping to shape the future 5 years, 10 years, 20 years from now. What do we want that to look like? Also, keeping in mind, how do we justify all those years of training? including, by the way, the fact that the federal government underwrites the majority of those residency slots, that we accept the federal dollars while we train, but then don't essentially pay back to our society subsequently. And finally, if we don't reimagine our future and how we want to shape it, others will absolutely do it for us. And they may not, almost certainly will not, have the best interests of our patients in mind. Next slide. So as we were working on this over the last year, we had to think about what are the needed skills. Changes need to be made to the system and the infrastructure. What needs to be added to training, such as team leadership becoming a critical skill? How do we support our current membership as we envision future needs? So keep in mind, we are a membership-driven organization. If people choose not to stay members or to join the APA, and our membership shrinks, so too does our ability to advocate and to help to shape the future. We need to provide value to psychiatrists and psychiatry trainees so that they want to be members of the APA. That's an intrinsic part of this. How do we shape the conversation and lead the changes rather than appearing to just fight to maintain the status quo ante? So again, for the purposes of this presentation, I would, just guide people to the APA website for our roadmap. It's downloadable, available. It has all the details and it addresses each of the domains that I spoke to, of data, of diagnosis, of how do we think about measuring severity and function? How do we access data? How do we then fund things appropriately so that we can drive access and equity? So with that, what I'd like to do is to transition to Dr. Charles Dike for his perspective, because he's far more eloquent than I am.
All right. First, I want to thank Becca, Dr. Brendel, for inviting me to this really wonderful panel. I always get lost when I'm listening to Bob talk. He's so good and so rich. So I just find myself learning just from watching you speak, Bob. Thank you so much. My task is fairly straightforward, I think. And I think it's straightforward because Becca and Bob have already set the stage. You're going to see some overlap, but I'm going to focus more on some of the tensions that Bob has talked about already. The subtitle is Tension in the Social Contract. There's a social contract, and there's tension in this social contract. We'll see why and how that happens. If this would advance. All right, just quick disclosures. I work for the federal government, state government, as well as Yale. But everything I say today, it's just my opinion. I've been told to make sure I show these slides anywhere. It's not getting old, but I have to show it. Yeah, so what is this social contract we're talking about? All physicians, including psychiatrists, have a contract with the society. And that is what the APA as an organization is meant to hold us to, this contract with the society, where the society expects us to treat them with competence, with altruism, that everything we do is in the best interest of our patients and of society, and that we, all of us, should be virtuous psychiatrists. We should be trustworthy, compassionate, empathetic, transparent, all those things that make people feel good when they come to see physicians. The society expects that of us. And we ourselves expect certain things from society, right? We expect the society to compensate us adequately, Dr. Trestman talked about all the loans and the amounts that people incur as a result of their training. So we expect the society to compensate us very well. We expect to work in a highly resourced, well-managed healthcare system. We expect society to respect us, to respect our autonomy, to respect our monopoly, and all of that are things we expect. But alas, the social contract is on life support. It's been on life support for a long time. It's going to be on a life support for even time to come in the future if we don't pay attention to specific things. And I just want to start by giving some examples of what some of my colleagues have already talked about. I became the the author of the Ethics Corner of the Psychiatric News, which is a publication of the APA, early last year. And since then, I've had like 21 articles. It's a monthly production. Of those 21 articles since 2022, there have been a few of them that have generated significant pushback, significant reactions from our members. And not surprisingly, one of them is this one that says outpatient psychiatric care is not for the poor. What is our obligation? And I began by describing some of what my colleagues have experienced when looking for psychiatrists. You try looking for a psychiatrist for your family member. First and foremost, you're not going to find any. But when you finally find some, you will see that many of them do not take any insurance. It's all out-of-pocket payment. And one colleague whose 17-year-old son needed psychiatric care finally found a psychiatrist who said it's going to be 2 hours, 1 hour to examine him first, another hour to examine you, and that's intake. And each session is $500. And by the way, we're going to need psych testing. Psychological testing is not covered by insurance. That's another $3,000. And I'm going to see you every week at a certain amount of money per week. And you can imagine how difficult that was. Who can afford that? Except for individuals who are really a small slice of our society. A vast majority of our patients cannot afford that. But that's what it takes to see a psychiatrist these days. And it's very difficult. Another article that raised significant concern. Last week, I was at the American Academy of Psychiatry and Law conference, and a group of doctors confronted me because of this article, apart from those who've written about it. The fact of the matter is, many psychiatrists have exclusion criteria for whom they accept in their private practice. So you call the office manager, and the office manager goes through this script with you, which includes any past history of suicide attempt, any self-injurious behaviors, past hospitalizations in the last 6 months, or multiple hospitalizations in the last few years, family history of completed suicide, all of those things, even substance use, depending on what type of substance use, are exclusion criteria. If you say yes to any of them, immediately the office manager will say, well, we don't have any openings. So what are the people supposed to do? What are patients supposed to do when they hear stuff like that? Somebody said to me that, Dr. Dike, I don't care what you've written down in this article. I'm not going to treat lawyers because I'm afraid of being sued. Again, so right off the bat, they're going to exclude lawyers. And where is the line? Eventually there'll be other exclusions, bias, discrimination. I don't treat certain people. This is a serious challenge that, as you can imagine, generated a lot of difficulty. The other is opioid crisis, reluctance of psychiatrists to prescribe buprenorphine. And I'll talk some more about this later on when I go to public psychiatry service. But the fact of the matter is, in the throes of significant opioid overdose, in the throes of the availability of material to manage this opioid use, majority of our psychiatrists are not using them. Our goal and our primary ethical injunction is to save lives. We have something that will save lives, and yet we're not doing it. And there are all kinds of reasons why we're not doing it. So these three and a few others generated significant reaction from our colleagues because it seemed like I was challenging them in a way that was uncomfortable. There's no doubt that there's ethical tensions, as have been described by Dr. Trestman. And one of the immediate reasons for this tension is that our ethical code, American Psychiatric Association Ethics Code, states that we are free to choose whom to treat. The Section 6 says a physician shall, in the provision of appropriate patient care, except in emergencies, be free to choose whom to serve, with whom to associate, and the environment in which to provide medical care. So every single individual who's challenged me from what I've written on Ethics Corner has quoted this to me. We have the choice. You can't force me to treat whom I don't want to treat, and so on and so forth. But that's not complete, because we also have a counter ethics injunction that says that our role is to support access to medical care for all people. Support access to medical care for all people. We also see that we as physicians should recognize a responsibility to seek changes in these requirements that are contrary to the best interest of our patients, which means all the advocacy efforts of the APA and some others that we're doing, we are required to do that so that we can change the environment of care to allow more psychiatrists to provide services to increase access to care, as opposed to just denying people care for reasons stated earlier. And psychiatrists have good reasons, of course, to worry about their care. A lot of them have been described by Dr. Trestman, but they worry about the fact that the insurance reimbursement is really terrible for the kind of service we provide. And then, of course, the issue of administrative burden. The leading cause of physician burnout or early physician burnout is administrative tasks. The burden is huge. And then, of course, despite the fact that the reimbursement is small, sometimes payment is delayed, sometimes you have partial payment, sometimes you have denial of payment. And then, of course, you have the requirements for technology, as also have been described earlier. These are serious issues that make it very difficult. So psychiatrists have a reason to worry and to do exactly what they're doing, but that can't be enough. That can be what we have to say. A quick comment about the public sector. Everything I have said so far had to do with private sector or private practice, but the public sector is not immune from some of them. Because when as a medical director of Connecticut Department of Mental Health and Addiction Services, we insisted that every psychiatrist in our system got trained to provide buprenorphine treatment to individuals who are suffering with opioid use disorder, and also all other types of substance use disorders. Despite the fact that every single psychiatrist in our system got trained and had the so-called waiver at the time, very few of them actually treated individuals with opioid use disorder. It became a real problem. And some of it maybe because liability concerns, because concerns around the fact that you need to have induction and so on and so forth. I was very worried because I thought that if we are in the middle of people killing themselves and dying, and we have access to how to save people, and this is what we're supposed to do as physicians, and we're not doing it, it's very difficult for me to find any excuse that is worthwhile. I just couldn't find it. And of course, that became a major issue. But then what then happens is, in the midst of all of that, there's now rise of non-physician prescribers who are taking over the space that we are abdicating for all kinds of reasons. They are coming in to help us out. And yet, on the other hand, organized medicine, not just psychiatry, has been pushing back on non-physician prescribers and therefore establishing so-called tough battles, rather than thinking about ways to collaborate, exactly how Dr. Trestman was talking about. How can we all collaborate and work well in this system? But that's not the issue. You found the stuff was when somebody says, I'm not going to take anyone who has attempted suicide, and then individuals who are less well-trained are managing very complicated problems. What happens to our patients? Does anybody care about our patients? There's an African proverb that says, when two elephants fight, the grass suffers. In this particular instance, the grass are the patients. The two elephants are psychiatrists on one hand, maybe non-physician prescribers on another, or psychiatrists on one hand, insurance companies. These individuals are fighting, but who's suffering are the patients. And in terms of even thinking about the training as described by Dr. Trestman, us being first and foremost physicians, and yet doing absolutely nothing in the physician space when we are treating patients, that's a real problem. Hypertension, diabetes, regular blood tests. Many of our patients they have no primary care physicians. We are the only physician they would see. And yet we're not checking, routine medical care or blood tests to monitor the effects of the medications we are giving them. And yet we're physicians. So this is a real struggle for all of us as we begin to shift focus on what about our patients. Now, this is a really exciting new landscape that we're all in. Things are changing. There's an evolving practice that is coming on to the field of medicine and psychiatry. And again, as mentioned before 2018, most physicians and most psychiatrists were in private practice. But 2018 was the first time when that shifted. More psychiatrists were employed than were in private practice. And of course, that led to an increased interest in the other players to come into this behavioral health space that was becoming extremely attractive. Venture capitalists, private equity firms, and so on. These individuals are investing into practices, or in fact, buying practices and becoming major shareholders in practices. And psychiatrists or whomever they employ become minor shareholders. Health plans are buying up practices and also employing doctors. So you see the mergers of CVS and Aetna and Optum. These are health plans that are now carrying out the functions that private practice doctors used to do. And then large hospital systems have also been employing psychiatrists. There are many, many opportunities with this. I think one of the things I would like to highlight is that there are opportunities that arise with these new players in our fields, but there are also significant risks. What are the potential opportunities? One is the fact that infusion of investment allows for innovation, expansion of practices, and so on and so forth, might be one. Another potential opportunity is that they can help streamline the headache, this administrative burden that is one of the major leading causes of burnout. These individuals have a way to help manage that, and that would be fantastic. Data analytics, we talked about PsychPro and gathering data so that we can measure what we do. These individuals can assist, digital health innovations. They can create work-life balance because in some areas they can be more flexible, but in some others they are not. And they can also enhance team-based practices. These are opportunities that exist. What about the risk? Here they are. A major significant risk is the fact that individuals who are investing may not necessarily have the same ethical goals as us. For us, the patient is at the core of what we do, right? At the core of it. For these individuals, profit margins, financial returns are at the core. And in order to achieve those things, some of the practices might be detrimental to psychiatry. In other words, they might have you work longer hours than necessary, see many more people than you can. The culture is no longer the culture of your practice, it's the culture of the entity that is investing into your practice. And this could be quite problematic for the doctors or the patients who would lose the personal touch, the closeness of their psychiatry. Now is all about checklist and what the system wants and how you want to move forward, because the goal has shifted, the focus has shifted from what is in the best interest of our patients to what is in the best interest of our partners and our financial investors and so on and so forth. Automatically, psychiatrists will discover a loss of control because, again, you have to abide by who pays the bills or who is investing on their culture, what they want. Loss of control. Surprise bills are bills that happen when in an emergency situation, let's say you are part of a health plan that has urgent care centers and so on and so forth, but an emergency situation, you can't get to the urgent care health that is run by your health plan, and you go to another one, and suddenly you have these surprise bills that are extremely difficult for you because they become a real problem for many people. And then there's the ongoing risk of fragmentation of care. If these investors invest in special areas of services or different groups, but you still have got to merge it with all the other areas where they're not investing. And so you might have this fragmentation of care with these new players. There are also newer players in the field. We talked about mental health apps. It was recorded that in 2021, there were between 10,000 to 20,000 mental health apps. You have online therapists and so on and so forth. Again, there are potential opportunities here, but there are also potential risks. You also have AI involved. So the immediate issue that became apparent with mental health apps is that an individual patient presents their concerns, but you don't know who's responding to you. Many of the responses are written, automated responses that are already fed into these apps, so that if somebody says this, this is how you respond. If somebody says this, this is how. So these are people who have been called automated therapists because of the fact that they have already been written into the app itself. And the other major issue is that this explosion of mental health apps have gone ahead of evidence. The development has gone, and the evidence for many of them is extremely thin, but nobody really knows that. Everyone is pushing it because of the business model, but this is a problem. Patient privacy issues are difficult and problematic. Transparency, like who's behind this app, or who's behind what is happening to patients in this new area. And then there's data is wonderful, but then you have to be careful as to what data, what data was input into these apps. Does it cover demographic information? Does it cover race, ethnicity, sexual orientation? Those important matters that might alter what kind of treatment people get, or what type of prognosis you have about them, or conclusions you draw. But the important thing is one has to be really careful, because garbage in, garbage out, and that's a real problem. Safety and legal liability concerns are quite problematic. And there was one particular case of a Belgian man who was engaged in who had an automated therapist mental health app for like 3 weeks. It was really very serious, ultimately committed suicide. And his wife was very upset with that, saying, maybe if he had seen a real person, he would not have committed suicide. So that's a risk. There's a safety concern, there are liability concerns, and so on and so forth. So to end, I'm looking at the time, there's a lot we can say about this area. The most important point to take home is the landscape is changing whether we like it or not. It's moving forward. What we need to do is find those opportunities. What we also need to do is to be very alert to where ethical concerns might be quite problematic to our patients. Our patients need us to be the vanguards. They need us to be the guys who are watching out for them. We can't shy away from this. We need to figure out how to make it work better, how to partner with these individuals and groups to make it better for ourselves as psychiatrists and for our patients as well. Thank you.
Thank you so much, Charles, Becca, and Bob, for bringing us through the ways in which some of the dynamics of the landscape have generated particular challenges for psychiatrists. And when coupled with some kind of longstanding traditions of physician discretion and thinking about the service of different patient segments, have produced a real kind of dilemma, I think, for the profession in figuring out how it's going to fulfill its responsibilities to the public. I want to turn it back to Becca for a moment, who's kind of been listening to the two commentaries on the work that's ahead and the tensions that exist, just for some initial reflections on how you see the APA as advancing, right, as an organization, as advancing the cause of psychiatrists in service to the public. So how do they reconcile the role that they play?
Yeah, thank you to Bob and to Charles for setting up such a provocative set of questions about the work. I thought I might actually come back and ground us a little bit in terms of the kind of ideas that we have about what psychiatry is going to need to do to begin to lead and on really what the core challenges is here. Which is to make mental health available, good mental health care available to everybody who needs it in a way that is accessible. So let me just share this slide. This is the roadmap that Bob alluded to earlier. And I just wanted to point out that when you see the pictures around the outside, these are the elements that we think primarily need to be addressed in order to inform setting up an infrastructure, sort of the legal practice, resource, financial, and practice structures that ultimately will support the work of advancing mental health care and achieving our goal of effective, high quality, equitable mental health care. So the kinds of things that we're thinking about really involve making sure that we're clear about good psychiatric diagnosis, what we're talking about, right? Making sure that the diagnostic and statistical manual reflects advances in science and in our field and really gives us categories from which we can diagnose patients, implement treatments, and have measurement-based care, understand if what we're doing is actually helpful. Coming up with clinical practice guidelines. This is something that's very important because it can begin to tell us, well, what are the circumstances and how could different members of healthcare, mental health care teams and healthcare teams partner with each other so that the person with the right level of training is available for the very complex patients, and so that we can make sure that everyone is practicing to the top of their license in collaboration with each other. All of this really requires us to have these large data sets, right? Data is, in today's day and age, data is king, queen, prince, and princess in terms of the ways that we can develop algorithms and knowledge through AI and other models to power our work and help us advance what we can do. So the PsychPro registry is really a pillar of getting data about our practice patterns, and as Bob talked about, really getting outcomes data that can help us understand what we're doing that's helpful. And unfortunately, given the long history of psychiatry, what we do that actually can harm people and really isn't helpful at all, right? So it was both kinds of sets of data. The PsychPro registry brings in systems. And so as such, we can also compare how we're doing compared to other mental health professionals to figure out how we collaborate in teams. That data can also help us with developing actual quality measures and standards to continually improve our work, and then also inform the kinds of education that we need to provide to psychiatrists and our other colleagues in other mental health and medical professions to be able to really know. It's very different to see a patient. Psychiatrists, most of us were trained in models where we did a lot of solitary work with our patients, right? But all of a sudden now, when we're talking about interdisciplinary teams, it's a very different skill set. So I just wanted to put up here exactly how much work is involved to power this, and then to think about how we use this, right, to set up the structures of reimbursement and a healthy workforce, equity, access, to be able to really come to realize our vision about a mentally healthy nation for all persons. So I'm going to stop there. I hope that adds just a little bit of structure and brings us back out to an organizational level about all the things that we're thinking about doing and need to do with an eye towards the moral core of what this mission really is on a grand scale. So I'm going to stop sharing and pass it back over to Kelsey.
Thank you so much. So, you know, we have some questions coming in the chat, which I'll raise up in a moment. But before we go there, I wanted to press on something of an organizational ethics question here, which is to say that, you know, in some of our preparatory discussions, there was the idea shared, and I think that, Bob, you were also bringing this forward during your comments, that if psychiatrists really want to be as useful to the public as they can be, they also have to be prepared to change their old ways. So it's not just about the systems necessarily, although as Charles highlighted, right, there's kind of this reciprocal relationship between the system and the person within it, and what's really possible for that person to actually hold themselves to over time. So really the question that I'm kind of asking is, Becca was raising that there's kind of the work of interdisciplinary teaming, for example, which once might have been anathema to a large share of the population, and in fact might still be something of an anathema to a large share of the profession. Similarly, you can't go to that group of people and say, what you're doing is wrong, right? So how do you think about organizational change? How do you think about shifting from what some of the current values or practice patterns might be into a new space without simultaneously condemning, right, some very long-held values, including things like discretion with respect to who we serve, or the practice patterns, for example, private practice or independent practice, or not participating in insurance. So this is a question about how we shift values within the profession and what is needed by APA as an organization to be part of that change in a productive way rather than a shaming or kind of retrospective way.
So I don't know, Charles, if you wanted to start.
No, go ahead, please.
So, Kelsey, this is fundamental to the issue and the way we even framed the whole roadmap. This is where we want and need psychiatry to be in a decade. We and all of us are doing what we believe at this point. And I genuinely believe everyone is a fair actor. Everyone is doing what they believe is appropriate based on their training and the needs of the population and the needs of themselves and their families. So how do we change this model? It is not happening overnight, and it's all about culture. It's the culture and the content of education. So we need to begin to reshape culture so that psychiatry is focused as a specialty on those with mental illness and addiction, and providing the leadership to other disciplines to optimize care delivery in other settings. We need to think about working with the ADPERT, the American Academy of Directors of Psychiatry Residency Programs, so that we redesign the education so people spend more time not just doing teamwork in inpatient, but doing teamwork as a leader in ambulatory settings. We need to evolve what we are doing, and we need to, at the same time, shift and train the environment around us. We need to look at making the reimbursement supportive and shape the reimbursement so psychiatrists are paid more when the care they delivered can't be delivered by anybody else. We need to make sure and train our psychiatrists so they feel comfortable, those in practice already, in managing medical conditions that are appropriate to their scope of training at their point in care delivery. We're not talking about them managing sickle cell or cancer. We're talking about fairly routinized management that's already algorithm driven in primary care. So we're talking about changing the culture, not just of psychiatry, but of our country, in terms of reimbursement, in terms of the way we are viewed and the way we aspire. So it's going to take years. It will not happen overnight, but the goal is to transform in the same way that we left a psychodynamically driven psychiatry in the 1950s into one that accepted cognitive behavioral therapy, and subsequently the battles between psychotherapeutic psychiatry versus biological psychiatry in the 70s and 80s to where we are now. And I think that this is going to be a culture evolution, but it's achievable.
Some of what I'm hearing, Bob, as you're talking, is the import of supporting individuals in making them comfortable with the new forms of practice and enterprise that a shift in values would require. And so it's not just kind of changing or kind of forcing people towards a new way of thinking about their roles, but facilitating what they need in order to feel comfortable in those new roles, and also thinking beyond values of psychiatrists more broadly to the society. I know that Becca and Charles probably have thoughts on this. Do we want to bring one of them in?
Yeah, I just want to add, first of all, I agree with everything Bob has said. But there's a fundamental trouble or troubling issue with how services are reimbursed in this country, which makes it very hard. Change in the future has got to include training, organizational change, but also individual practices that have to change. One example is as a private practitioner doing only med management, so to say, which is what you're being reimbursed for, everyone knows that in order for you to provide solid med management, medication administration, you're going to have to do some psychotherapy. In fact, some of my patients would come to me for psychotherapy, even though I'm being reimbursed for only medication management, and time is going. So the way the system frames this is so problematic that it makes it very hard. Now, how is it for an individual themselves to enhance services? If I'm in private practice, one of the things I said is that some of our colleagues should maybe set aside about 5% of their income for the individuals who can't afford them. And many psychiatrists do sliding scale and all the other things, but maybe find other ways to invite those who cannot afford your services. On the one hand. On the other hand, they still have got to feed their families and send their families, their children to the top schools, and it's a very difficult place to be. But I think just focusing on all of these ideas, and because it's going to be multiple different ways to come together, it's not just going to be one thing that's going to move this forward. Where I trained in England, as a psychiatrist, you're first and foremost a physician. So we managed all the physical health issues, unless it got beyond what a regular physician can manage. Then we invited others. Well, that's not the training here. The training for psychotherapy is gone because these days, psychiatrists are not supposed to provide psychotherapy. Meanwhile, we have to. So I think all of what Bob said, I agree with, and just making sure we also focus on our own role in this as well.
So I want to sort of broaden out this conversation a little bit, because we often go back to sort of this old false dichotomy in psychiatry. Do you do talk therapy or do you do medication management, and how do we treat patients? And I think nowhere in this are we saying that psychiatrists are not professionals who should be able to have autonomy in their careers and think about the ways in which they'd like to treat patients and the kinds of practices they want to have. Instead, what we want to talk about, what we really want to be talking about, is how we make sure that the work we do is actually advancing mental health and contributing to solutions for the fact that we are a limited commodity with lots of different responsibilities as individuals, both to ourselves and to society. But that as an organization and leadership in psychiatry, we have a very important role in putting forth a message and highlighting the responsibility that we have to lead, to make sure that we have mental health care available to those who need it in this country. There are a lot of questions, for example, in the chat box about why do psychiatrists do such a bad job of understanding people with serious mental illness? I don't know that all psychiatrists do, right? But the general idea is we have not done a good job of addressing health equity for those with serious mental illness. Right? Those with serious mental illness have a 25-year shorter life expectancy than the average population, right? So they have poorer outcomes when when they receive a medical diagnosis compared to others with the same diagnosis. And we we are starting to make some inroads in that, but we've missed a lot of opportunities. The other piece that we really haven't talked about here is that we've gotten into this place that we oftentimes end up, which is that we're talking about psychiatrists versus other mental health professionals. But there's another piece of this puzzle as well, which is that the majority of psychiatric care, and I'm just going to share my screen for a second, because this is also a really important piece of the puzzle. is that psychiatrists, in fact, we're deluding ourselves if we think that we are taking care of all the medical psychopharmacology for people with mental illness as well, right? So that if you see the middle bullet points here, 43 to 60% of treatment for mental illness occurs in primary care settings, and really only about a fifth of it happens in specialty mental health settings. So this is really, really important. And even at a very basic level, right? We're not equipping our primary care physicians to be able to access mental health services when they need help either. So PCP practices do a great job when they need to make a cardiology referral. 80% of them know who to call. They have clear procedures for referrals, and they get their patients seen. Right, that's a little bit less when you get to endocrinology, when we think about things like diabetes, another common illness, right? When we get to things like anxiety and depression that are very, very prevalent medical conditions, we drop well beneath 50% of primary care practices knowing what to do about that. So I think that there are also other options on systems level, which is why this is an organizational ethics crisis, really. For psychiatry, more so than just thinking about, okay, what should individual psychiatrists do, right? And I think if we're going to, we didn't talk about this today, there are a number of evidence-based models that, that support the ways psychiatrists can work with primary care practices. One is collaborative care. What's exciting about it, and really highlighting why this is a problem that's not about individual physicians, but about systems, is that if you develop a model where you use a psychiatrist and a care manager together in a primary care practice, you can actually increase the number of patients that a psychiatrist can be involved in the treatment of in a consultative role by a factor of 20, right? So that's an order of magnitude. If we're going to get really, really serious about this, we need to come up with the data and the solutions and the structures that are going to allow us to multiply our effector arm by another order of magnitude, right? We can start getting really excited about this when we get to 100, right? I'll take the factor of 2 also. I'm happy to go to 200, but 10 isn't going to get us there. 100, maybe we could start. And 1,000, then maybe we'd be really making a difference. So I think sort of drawing this out in our last moments to why this is something that's an organization or systems level concern, as opposed to just the practice patterns of individual psychiatrists, is what made us so excited about being able to come here today and share our work with all of you. And I think with that, Kelsey, maybe I've stolen the last word without permission. So I'll pass it back to you to send us out for a beautiful Friday afternoon in Boston.
Well, I really have to thank the three of you. I think one of the things that this work models so nicely, as each of you alluded to, is the fact that as an organization, right, APA is situated in such a way not only to set the norms, right, and the targets of the profession, but also to work at this systems level through its advocacy and policy work to actually create the environments within which it is possible for psychiatrists to meet their responsibilities to the population in collaboration with other mental health practitioners. And so this is really a model, I think, of a way that an organization can both look internally with respect to the individuals that it can influence, as well as beyond, right, into the systems and policies that are actually shaping what is possible for those people to achieve. So it's a beautiful model, I think, for us to consider in this consortium, and yet we can see why it is so hard, right, to grapple with some of the emerging trends and dynamics that have really put pressure on the profession to rise to its kind of greatest possibilities here, build the data, build the diagnostic support, build the capacities and training that is needed for the future. So I want to thank all three of you. Charles just jumped off to do his work for the state of Connecticut. And the perspective that I think I can bring from the Organizational Ethics Consortium is that you've shown us that even within these complicated kind of system dynamics and interprofessional dynamics, there really are ways for organizations to sort through and vision in horizon scanning, instead of saying, we need to change this tomorrow, right? And in so doing, lose the possibility of actually carrying forward a broader vision. So thank you to the three of you, and thank you to everyone for your thoughts in the chat box and for your attentive participation in today's work. Have a wonderful Friday. We'll see all of you back in December 1st for the Organizational Ethics and Clinical Ethics Joint Consortium. Good afternoon all.
Thanks, everyone. Be well.